So my work experience has mostly been with people with addictions that are street-based or have used shelters as their accommodation. So I'll speak from that perspective of working with that population of people with experiences of addiction. I think the key thing to remember is it took a lot of coordination and courage for that client to arrive in hospital. I know locally here in Lethbridge, agencies that have historically transported from shelter to hospital have changed their eligibility criteria where, pickup at shelter spaces are no longer part of the mandate. And so for community teams, an RN like myself on a community team, sending a client to hospital when they're not in a life-threatening situation via ambulance also doesn't seem fiscally prudent. So, we do what we can to coordinate that transportation to get them to the doorsteps of the hospital, because what they are presenting with is likely exceeding our capacity to manage in the community. Perhaps there's lack of primary care services. Perhaps it is a health condition that's worsening. And I think to look at it from a different perspective, a lot of these clients, especially a street-involved population, has a lot of social markers that expose them to discrimination and dismissive care that they've experienced previously in hospital. So they're also not jumping at the opportunity to go to hospital. So it takes a lot of courage for these street-based clients with addictions to present in the first place. So I think that's a key thing to remember, is their journey that it took both for the community medical teams and for the clients to be there in the first place and then to stay there. So I think it's an important point to keep in mind, because they're there for a reason and we want them to stay to finish their treatment so it doesn't become sort of this revolving door or back and forth process of sending them out or for them to leave against medical advice before the treatment's completed. I think the first, which is something we do with every client and every family and every community member, is to let them know who we are, our role in their care, and what they might be able to expect. So it seems really simple and basic, but it really does settle anyone, in particular someone with, again, from a street-based population with experiences of addiction, to kind of settle into what could be a very foreign place. Like, hospitals are full of machines and foreign language that it's hard for many people to navigate. So introducing ourselves, my name's Carina. I'm an RN on this surgical floor. You are here because X, Y, and Z. And then asking them what they like to be called. I know a lot of the clients that we see in the community don't go by their legal name. So I guess it's, one more way to put them at ease, to know that you're extending them the respect and dignity that you would extend to any patient that arrives in hospital, and that they're deserving of the time that you take to get to know as something as simple as what they prefer to be called. And have the opportunity to have that conversation to start off that relationship as a nurse, between a nurse and a patient. I think the second point that might be helpful for some nurses that work in the hospital is to also ask this particular patient whether there's a support person they would like you to contact. Again, coming into the hospital can feel like a very jarring experience, especially if they've had some less pleasant or less optimal experiences in their past. So, a support person might be their family, and it might not be. It could be a staff member who works at the shelter they stay at. It could be a member of their community team that's been supporting their medical care. It could be somebody from the harm reduction services or somebody from the addictions and mental health portfolio. So asking that question of, is there a support person they would like them to visit them or to support their experience in hospital, might settle some of those initial discomforts and anxieties, and may also help with some of the medical interventions that they might be facing, especially if it's a lengthy stay. I think the last piece to that is, don't forget you also have a lot of addictions and mental health services available within your health authority. So I think, speaking from the perspective of Alberta, we have within our health authority here an opioid dependency program, and we get regular calls from our inpatient colleagues asking about opioid agonist therapy medications. Like, The other day at clinic, we had a call from a nurse that worked in postpartum, curious about the dose of Suboxone that a new mom was receiving. Suboxone is opioid agonist therapy medication we use for opioid withdrawals. And so, she was alarmed at the high dose that this mom was being prescribed and wanted to know a little bit more about, usual approaches for prescriptions. So it led to some really good discussions between us as an ambulatory clinic with an inpatient colleague about how to manage these situations for those who are living with addictions but admitted to hospital. I think the last thing I'll offer in terms of building that therapeutic relationship is plan with them, right? Even something as simple as in the language that you might use, such as, this is what the medical team is thinking, this is the plan, and I think we're going to do this today. How does that sit? And, recognizing sometimes they might not truly have a choice in deciding on the medical team's approach, although I guess they could consent or not consent to the procedure. It's that attempt to involve them in their care and letting them know what's going on in the next 8 hours or 12 hours you might spend with them. And again, a question such as, what's one thing you want me to address in the next 8 or 12 hours that we spend together? Or if you don't get to that, offering something like, we didn't get to that today, but I will let the oncoming nurse know or the charge nurse know that we had discussed this. So, nothing too different from how you would care for any other client that might present, but knowing that this is a population that's traditionally probably experienced a lot of barriers in accessing care. I think, and so in addition to planning with them is also knowing who you are as a care provider. What are some of the assumptions that you bring to caring for this client? What are some feelings and thoughts of discomfort that might surface? I know for me, even working with this client population in the community for the past, 17 years, there are situations where I feel like I'm being pushed in my boundaries. And, it's okay that you might have feelings of frustration or feeling like there might be some behavior that are challenging. Keep in mind that this population has had to survive on the streets. So yes, they will push and negotiate some boundaries. So, knowing where you stand and who you are as a care provider, and then also knowing and giving yourself a permission to step back if it's no longer a therapeutic relationship. Again, I've done that in my experience as well, knowing that our previous experiences with one client hasn't been pleasant. I would say to a colleague to say, hey, I don't think I'm the best suited person to engage with this client today. Would you mind, taking over their care? And so it's knowing yourself and knowing the client before you. I think I'll speak from the experiences of clients who have, left the hospital and have spoken to us from their experience. I think the one thing is to not always assume that changes in their physiological health is always because of the addiction that they live with. It might be, and likely it might be, but always kind of keeping that space open of like, well, it could also be something else. It might be because they were in a lot of pain, maybe because their oxygen saturations were in the pits, or other, existing disability that they might have been living with unrelated to being intoxicated or in active withdrawal from addiction. In other words, like their addiction isn't the only defining character of them as a person, nor of their medical condition. Like I'll use an example of a client that we see fairly often in the community here. He's lived with physical and developmental disability since childhood, and he has a speech impediment that sometimes is often mistaken as signs of inebriation. And so sometimes when he presents to hospital, the assessment might not be as thorough because they assume that they are intoxicated. So all that to say that rule out and assess other causes of changes that you might suspect, again, maybe because of other stimulus like pain or infection. If they're acting confused, it might be something as simple as an O2 set. I don't know. But remain open to the possibility that what you see either in changes or behaviors or symptoms that it's not always only related to the addiction. It's part of the picture for sure. And to look at it another way, think of these patients as coping with the priority health concern of why they're there on top of those impacts of active withdrawal, which is not, insignificant for someone who might be actively using before being admitted to the hospital. I think at the end of the day, knowing that we did what we could in caring for this one patient in this one visit to improve their experiences and to improve their health is probably the ultimate goal to aim for, right? We can't change the world, we can't change their experience of the acute care system, but we do have the capacity to make them feel they were cared for, or that we took them seriously in this brief stay in the hospital. Yeah, that's a good question. I think there's always help. I think, it's okay to not know what to do when you have a patient in hospital that you have to care for who has had a long history of addictions. And again, especially from a street-involved population, rely on your colleagues, rely on existing departments that are familiar with this particular population, just to get a sense of what they do that's helpful. And it might be something you might not have time to explore in a busy acute care unit. Maybe this is something for your social worker colleague to navigate and to kind of map out those existing networks, but knowing that you don't need to have all the answers. But first and foremost, knowing who you are and what your assumptions and feelings might be towards caring for a person with addictions might be the first step, knowing yourself and knowing another person, and particularly a patient you care for in hospital.